Okay, until I can get a better roll or something, this is what we need to use until I can get better equipment. Now, direct oral tracheal intubation of the pediatric patient is almost exactly like the adult. There are just a few exceptions here, okay? You're obviously going to check and make sure you've got all your equipment. Oxygen, BVM, appropriate size mask, airway adjuncts. I might need to get you a teeny tiny one for him. Oh, that might work. I'll get y'all a tongue depressor too. Because y'all remember, for infants, how do we put in an oropharyngeal airway? With a tongue depressor, we slide it down the anatomical curve. We don't put it in upside down and flip it over like we do on adults. Okay? So I'll make sure you have the right size OPA and the tongue depressor in just a minute. ET tubes, we have all the pediatric sizes on the bottom here. He probably takes a 3.5, 4. Capnometry, capnography, PPE, open the airway, ventilate your patient. Okay? Insert the OPA correctly. We're going to ventilate at a rate of 12 to 20 breaths a minute. Just a hair faster than we do adults, right? So it's 1 breath every what? Instead of every 5 to 6 seconds, it's every 3 to 5 seconds. Thank you, Mitch. Put the pulse ox on. Pre-oxygenate your patient. Now here's where we have a difference. When it's time for you to intubate, you're going to check your equipment. You're probably going to use either a 0 or a number 1 straight blade. We have always recommended straight blades for infants. Because of the large floppy epiglottis, it can actually grab the epiglottis and lift it. The vallecula does not work for infants and young pediatrics. They do not have the musculature or the tendons that have developed in the adults for you to get the curved blade into the vallecula and lift and get that lift on the epiglottis. For peds, you have to actually grab the epiglottis and lift it.
What size do you want us using on these?
Either a 1 or a 0, and I'm going to go get you the other kit, because the other kit actually has the pediatric handle. And who put this in there? I didn't need to put that in there. All right. So, check your equipment, make sure you've got everything you need. Please note that your pediatric tubes do not have what? No, they have stylets.
The ball.
They don't have a cuff. So we don't need, we do not need a syringe. So, before you start, you're going to place padding under the shoulders, between the shoulder blades, to lift the shoulders up and place the patient in a neutral inline position. That's a registry skill thing, guys. When you go to a registry, this is one of the stations they do, and you must do that. That is a fail point. Forgetting to elevate the shoulders. Even though the mannequin doesn't have shoulders, and they've already got them lifted, as you can see on this mannequin, you need to verbalize elevating the shoulders. Okay? From here, it's intubating just like you normally would. You would take the head, you will insert, you're going to need to get the tongue and go very deep. And I'm going to make sure we lubricate these before we... you need to grab the epiglottis, making sure you stay off the gums. Visualize the cords. Insert between... Yeah, 3.5 is good and 1 is good. Place your capnometry. Ventilate your patient. Checking your capnometry. Have your partner check for clear bilateral breath sounds. Please don't let go of this tube because, especially these, there's no cuff. They're wedged into the cricoid cartilage. And ventilate your patient. As I said, almost exactly like adult intubations, but not quite, and definitely more challenging. At that point, you'll verbalize what? Securing the tube.
There's not a tube restraint for the pediatric?
There are pediatric tube restraints, but they don't come in all sizes, and they don't always fit little bitty babies like this.
A lot of tape.
So tape would be a good thing if you don't have a commercially available tube restraint for a ped or for an infant. You know, if we had the pediatric mannequin, we actually have tube restraints for peds. But I've never seen a tube restraint for an infant that was similar to what we use. They do have something that's really funky. It looks like a Y that tapes to their face. And
So let me ask this: what would be the best way to secure that tube?
tape.
Well, no, I understand that, but which direction?
I would go to the corner of the mouth and tape it down that way.
Okay.
Okay, and you can verbalize that here on this one. Okay, since we don't have commercial tubes.
Well, I mean,
tube
I don't
holders,
think
right?
we have them either, but I mean, that was just a...
I would take the tape that was in here, because I thought I had tape in here. So let me make sure I caught everything. Verifies, assesses for hypoxia, secures the tube, ventilates patient at a proper rate while observing capnography. Yes. Okay. Critical criteria: failure to ventilate within 30 seconds after taking PPE, or interrupting ventilations when SpO2 is less than 90% at any time. So we need to ventilate to get the kid at least up to 90. Then we can start prepping our stuff and getting ready to intubate. Failure to take PPE. Suctions patient for more than 10 seconds. It's all right, I'm not having y'all suction. The stylet goes beyond the end of the ET tube. We all know that's bad, right? Uses the gums as a fulcrum. You don't have to worry about disconnecting the syringe because it's an uncuffed system. Ventilates at improper rate. Failure to auscultate. Remember I said have your partner check for proper placement. And it actually says bilaterally and over the
Should
epigastrum.
we see if she wants to practice?
Over ventilates.
Should we see if she wants to practice?
No. It's a high school student.
She first-hand experience on her.
She like tattoos and stuff.
Hmm?
She had tattoos.
She's a high school
She's
student.
high school student.
You can tattoos whenever with parents' consent.
Or if you are 18 and still in high school.
Or emancipated. Or pregnant.
And then of course does anything. Oh guys, please, when you notice when I ventilated, I was very little, just enough to what? Inflate the lungs, rise the chest. Okay, we don't want to be over ventilating. It is very easy to cause a pneumothorax in a pediatric patient. Okay? So please do not do that. All right, let's. You know what? That looks like a good team right there.